get started. So what I want to do is sort of go through an approach with people who we first see in our clinics and talking about new diagnosis of Charcot-Marie-Tooth disease and some things to consider as part of the evaluation. Now, common questions people have when they first come in are they want to know, what is Charcot-Marie-Tooth disease? Do I have CMT? And if I do, what are the different types and how are they separated or classified? And in the talk that follows me with Carly Siskin, who's just a superb genetic counselor, we're going to go over, she'll go over details of genetic testing and what can it tell us about our CMT. And then finally, when people come to clinics like ours, we're part of the Inherited Neuropathy Consortium and some other CMT centers of excellence, what are all the things that we're doing in those clinics besides just doing quick exams and making a diagnosis? So I'm going to start by just saying what CMT actually is. It's named for three doctors who did work in 1986. That's Jean-Martin Charcot, who is the father of neurology. He also was the first to discover ALS, multiple sclerosis, and a number of other disorders. His student, Pierre Marie, and finally, in England, Howard Henry Tooth. So Charcot and Marie were in France, Tooth was in England. They didn't know each other. And in fact, in France, they still call this a disease of Charcot and Marie, and Tooth gets booted. But in any case, for us, it's going to be CMT. And what does CMT mean? Well, it's a disorder of the peripheral nervous system. And I'm not sure if you can see my arrow here, but in the middle, the brain and the spinal cord, they're in the center of things. We call them the central nervous system. But in order to get down to the hands and the feet, in red here are nerves that have left the spinal cord, and they're in the periphery, and they're called peripheral nerves. And those are the nerves that get affected with Charcot-Marie-Tooth disease. And we tend to classify these based on what part of the peripheral nerves get affected. So this is the middle, the nerve fiber itself, we call that the axon, and it's surrounded by myelin insulation here. And with CMT, we separate these out into disorders that we call CMT1, which affect the myelin, and disorders that we call CMT2, which affect the axon. And the presentations on patients can be very similar between the two types. So it's often requires tests like a nerve conduction test, which we'll talk about, to determine. And we'll get into the reason why it can be important for the caregivers and the patients to know the distinctions as to what type it is. And as I look at this slide, I realize that this and many of these slides are the gifts of Shauna Feely, because I'm totally incompetent on trying to make slides, and she's a good friend. So please, if you like the slides, congratulate Shauna. And if you don't like to talk, you can blame me. Now, this also gets confusing for many people who come to the clinic because there's historical classifications of CMT that don't really have things to do with things like CMT 1A or 1B, which we'll talk about in a minute. So over time, before they knew the genetic cause of different types of CMT, patients were told they might have Dejerine-Sodas syndrome, which just means a severe form of CMT that affects infants and children. The same is true for congenital hypomyelination. And often people with CMT will have tremors. And these are two more students of Charcot, Russi and Levy, and they recognize tremor as part of CMT. And that's called the Russi-Levy syndrome. And I would add that Dejerine and Sodas were also students of Charcot. And then sometimes people have increased reflexes instead of decreased reflexes, which we're starting to separate out now. And I'll talk a little bit more about that in a few minutes. But that was called CMT type 5. And some patients have problems with optic atrophy, and that was called CMT type 6. And we sorted that out a bit as well. And then in terms of what is CMT, Classically, it's been thought of as people who have weakness and sensory problems, so sensory motor neuropathies. But in the current era, as we learn more about the genetic causes, we now include under this umbrella people who have pure motor forms of peripheral neuropathy that are genetic, and that would be like distal hereditary motor neuropathy. And getting back to the CMT type 5, people who have increased reflexes, we might call that hereditary spastic paraplegia, and some patients have primarily sensory neuropathies. So I hope that's not too confusing, but we're going to sort of leave that there and try to be less confusing going forward. Now, until 1991 and 92, there was no genetic cause known for any type of CMT. And although we still can't cure any of the forms of CMT, we've been able to learn a lot since that time, and we now know that there are genetic causes of CMT on almost all the chromosomes in our DNA. And in fact, we have over 100 different genes that can cause CMT, and we're learning to identify more, if not monthly, pretty close to it. And so when people come in, they want to know how to determine what type of CMT they might have. And one of the things that happens, and Carly's going to go into this, is that we try to figure out how it's passed along in a family. And there are different ways that they can be passed on genetically. If they're demyelinating and they're autosomal dominant, and I'll talk about that in a minute, we call that type 1. If they're autosomal dominant and they're axonal, we call it type 2. But some types of CMT have their mutation on the X chromosome, and we call that CMT1X or X1. And as we'll see, they can have intermediate nerve conductions. And then some types have what's called autosomal recessive inheritance. And again, Carly will go through this, but I'm just going to talk about it very briefly, just so we can put it in a little bit of perspective for her talk. So autosomal dominant type 1, that means it's a 50% chance of passing it on from one generation to the next. But sometimes it can start just out of the blue in an individual person, and then we get passed on with a 50% chance to the subsequent generations. And type 1 examples are CMT1A, 1B, 1C, and 1E. And those are identified by genetic testing. In type 2, it's still autosomal dominant, but in this case, it's the axon that's affected. And I'm going to see if I have a little thing here, see if I can hide this. I just totally screwed this up, sorry. Bear with me. Okay, so hopefully you can still see this. So in type 2, again, an example here would be CMT type 2A, which is caused by mutations in a gene called mitofusin 2. Then we talked about X-linked. So the importance of X-linked disorders is that the inheritance pattern is a little bit different. In this, a male can't pass it on to their son, and females are typically less affected than males, though not always. And you can see the examples down below. And CMT1X is actually the second most common form of genetic CMT. And finally, the recessives can be axonal or demyelinating, and you need to inherit a copy of the mutation from each parent. If you only get one copy in type 4s, then you're asymptomatic, typically without evidence of neuropathy. You need to have 2 to actually have the disease. And I'm going to leave more discussion on this to Carly's talk. Now, this is just a picture of an individual with CMT who's coming into the clinic. And we've examined him and see that he has features. He has weakness in his feet and ankles. He has weakness in his hands. He has loss of sensation and problems with balance. And we want to try to characterize what type of CMT he has. So we've taken a family history, but now we're going to do people's least favorite test, which is a nerve conduction test. But I want to show you how this is helpful. So here is results from a nerve conduction test. Now, some nerves go to muscles, those are called motor nerves. Some nerves go to sensory endings, those are called sensory nerves. And one of the nerves is the median nerve and the ulnar nerve in the arms, the peroneal nerve in the legs. So if you look out here under NCV, this stands for nerve conduction velocity, the speed of which impulses are conducted along the nerve. And these numbers are in meters per second, roughly the equivalent of yards per second. And they should conduct in the median nerve more than 38 or here 48 meters per second. And you can see here's the value in our patient. It's 23 meters per second. It's too slow. And the same thing is down here for the ulnar nerve. It's 20 meters per second. All of these nerve conductions are too slow. On the other hand, the size of the waves, which we call the amplitude, they're in black here, these are normal. So we know that this is a demyelinating type of CMT. So we might think of things like CMT1 here. Hopefully that makes sense. Now, if it was CMT type 2, classically it would be reversed, so that these numbers here would be closer to 38 or 48, for example, but the size of these waves would be too small. So this is what we look at for to try to characterize if somebody has CMT type 1 or CMT type 2. And the same thing is true for the sensory nerves, which are slow here. Hopefully that makes sense. But that's important because, as we'll get into with Carly's talk, there's lots of different genes that can cause CMT. Not all of the changes we find are disease causing. And it's important for us to know whether the nerve conduction data fits with the genetic data. And this is just a slide just to show that different conduction velocities give us clues as to what the likely cause is. And I'm not going to go through this in detail, but if nerve conductions are in the range of 15 to 35 meters per second, that's often very suggestive of CMT type 1A. If they're less than 10 meters per second, it gives us a clue it might be another genetic cause, and helping us make sense with the genetic testing. Now, this is just an example to look at one other patient. And if you look at the nerve conduction velocities here, you see they're a little bit slow. They're 32 instead of 38 or 48. And these we call intermediate. And there was no male-to-male transmission in the family history. So this patient, actually, I'm not going to spend a lot of time on this, despite what's written on the bottom there. Ultimately, it turned out that this patient had CMTX. Now, what we've talked about up to this point is people who come in who have peripheral neuropathies, but typically that's their main finding on history and exam. But with the progress in genetic testing, we're increasingly finding that there's some overlap, and some diseases aren't just simply peripheral neuropathies, but they have other features. For example, some patients we talked about might have optic atrophy. Some may have increased reflexes that we would call spastic paraplegia. Some may have some problems with balance that are even more than you would expect for a peripheral nerve problem, and they have ataxia. And it's just next generation sequencing is enabling us to sort of find some of these overlapping syndromes. And the reason I'm mentioning it is that not everybody has pure CMT. And that's a challenge for the caregivers as well to figure that out. So I'm going to move next to what patients in a way should expect when they are evaluated for their CMT. And what I want to point out in this slide is it's not just an interaction between the neurologist up here and the patient to make a diagnosis, because although we don't have cures to make CMT go away, there are many approaches to help people with CMT, enable them to do more things and to improve the quality of their life. And that is sort of at the heart of multidisciplinary clinics. And multidisciplinary clinics are really required for most inherited neuropathy consortium sites and for CMT-A centers of excellence. So a typical multidisciplinary clinic would have a genetic counselor, because genetic counselors are, as you'll hear from Carly, are really knowledgeable in how different genetic diseases can get passed on, and how to do the testing, and how to do testing in ways that are commercially sustainable for the patient. And really, I would just say in the more than 20 years of our clinic, genetic counselors have been at the heart of our clinic. But there are also things that are needed with requiring stretching, what exercises to do, what's helpful to enable patients to do the best they can with their CMT, and physical therapists really are instrumental in helping with that. And as many of you know, hand functions are really challenges for things like buttons, doing fine movements, fastening jewelry, cutting food, picking up small flat objects. And so maximizing a person's ability to use their hand function is really an essential part of care for CMT. And we've been blessed to have excellent occupational therapists. For many years when I started out in medicine, I thought occupational therapy meant helping people find jobs, but that's not correct. Occupational therapists really are devoted to helping with hand function. And they also play a role in many cases in facilitating even things like transitioning in driving to help move foot controls, arrange for foot controls to be moved to hand controls in cars. So the occupational therapists have been a big part of our clinics. Many patients need orthotics and ankle supports, and there are all kinds of different bracing available, and we'll get to that a little bit in some of the questions. But an orthotist is a big part of management of people with CMT, and there are instances when foot structure problems can't get corrected with bracing, for example, that orthopedic surgery is necessary. And this requires a surgeon with expertise in foot and ankle structures, not just a general orthopedic surgeon. And finally, on this little spoke wheel are pediatricians. So many, though not all, forms of CMT present in childhood, some more severe than others. And particularly as we move towards getting treatments in CMT, there'll be increasing emphasis to try to develop treatments that are effective in kids before some of the consequences of the CMT progress over the years. So having pediatric input into a clinic is really an essential component. So again, this is just an example of the multidisciplinary care. But when you're getting your CMT evaluated, these are all needs, in my opinion, that patients have to really get managed effectively. And it can improve the life of patients with CMT. Now, I'm going to move a little bit to talk about what's called the Inherited Neuropathy Consortium, which is a network of CMT centers of excellence from around the world who are doing research on CMT. We're in our 13th year of existence, and every single year of this has been supported by the Charcot-Marie-Tooth Association, and who helped us jumpstart this even before 2009 when this started. And we also get support from the National Institutes of Health and the Muscular Dystrophy Association. And the reason I'm putting this up there is that when people come into the INC clinics, we do our best to give the care that I talked about on the previous slide. But in addition, we are wedded to try to develop therapies that are curative, along with organizations like the CMTA, and to do that, we need to have good natural history for the different types of CMT. We need to know how they progress. We need to be able to measure the progression, and we need to be able to measure the progression in multiple ways with the different outcome measures, so that if we have treatments or medications, we can tell if the medications slow progression or improve patients in a way that we can actually measure and be confident in. And these are just an example of those. Those are called natural history studies. We also look at blood samples and sometimes even skin biopsies to identify biomarkers, to look for biological markers of disease progression that we can tell if they are improved with treatment. And we, again, also, people like me love what we do, but we're not going to be doing this forever. And so there's a need for new investigators and new people to run these multidisciplinary clinics. And so we are training those as part of the INC. Now, I also want to say that the CMTA obviously reaches out to sites that are not just sites that are members of the Inherited Neuropathy Consortium, but other centers of excellence that can provide good care for CMT patients along the lines of what I talked about. So I sort of feel like I've rushed through some things in a bit of a whirlwind, but I wanted to give you an approach of, I think, how patients get evaluated with CMT, and some of the reasons that we do the evaluations we do. But I recognize that many people have questions, and so I want to devote the rest of the talk to addressing those questions about their CMT. But I thought I'd start by just going over some of the questions that I frequently get asked, which may take care of some of these. So again, this is coming from experience in CMT clinics since 1996. So patients want to know how their CMT will progress. And the answer is it's different for different genetic types of CMT, and sometimes for different mutations within the same genetic type. So that is sort of an individualized answer. And we know more about this now than we knew 20 years ago because of these natural history studies. But again, it's not something that can be predicted across all CMTs, because CMT is an umbrella term and the different types are different. Patients often ask, will affected family members have the same type of CMT as I have? And the answer to that is almost invariably yes, because CMT runs in families because that mutation runs in families. It is possible in rare cases for there to be two causes of CMT in a family, but again, that's an extremely rare circumstance. We looked a few years ago and we found 11 total patients out of the thousands that we've evaluated in the INC. Who is at risk in my family? Well, this is going to be discussed a bit in a bit more detail by Carly, but it depends on the type of CMT that's in the family. So if you have type 1 or type 2, there's a different risk factor than if you have type 4 or type X. Excuse me, I'm just going to take a quick sip of coffee here. So the next question we're often asked is, are there foods or vitamins that I should take or avoid that would help my CMT? And the answer is that researchers have looked for years to try to find various treatments, including foods and vitamins that would help improve patients with CMT. And all of those studies have been negative. So there's no food or vitamin that can actually serve as a medication to make your CMT better. Having said that, there's some common sense sort of ground rules that because CMT makes people's ankles weak, it puts a lot of stress on the ankles, the knees, and the hips. And so things that can help with that are really helpful. And so watching a person's weight is like an important thing to, uh, uh, and to maintain a healthy diet, simply to actually allow your body to do the best as it can without having to deal with the extra weight. And I didn't put medicines on this. I think I just forgot to. But in terms of medications to avoid, there's lots of lists, including those by the CMTA. But in the end, people in the field believe that there are probably just a handful, like 3 or 4 medications that really have been shown to make CMT worse. And those are typically some of the anti-cancer drugs. And so if there's issues, you can discuss those with your caregiver. But again, most medications are fine to take with CMT. And personally, I'm not aware of any literature that supports risks for different anesthetics as well. The next question that we often get is about pain in CMT, because there's sort of a literature in the past that, well, people with CMT don't have pain. And that's false. People do have pain, and it generally is in 2 types. So particularly in people when they get into their middle years, there's been a lot of stress on ankles and knees and hips, and arthritic type pain in joints is very common in CMT. And that pain typically gets managed like arthritic type pain gets managed in people without CMT, with non-steroidal anti-inflammatory drugs and related drugs. About a quarter of the patients with CMT report what we call neuropathic pain, which is things like burning and tingling, and often this can be severe. And treatment for this isn't perfect, but it often involves a couple types of medications. One are medications that were originally designed as anti-seizure medications. And examples of this are gabapentin, or also known as Neurontin by a brand name, or pregabalin, which is often known as Lyrica. And these medications, again, help with neuropathic pain, and they have to be used in a dosage-related manner. And for most people, they don't make the patient sleepy. But again, there is some individual variation there. The other type of neuropathic pain medicine that's commonly used are what are called antidepressant medications. But these medications are certain antidepressant medications which have properties that help with neuropathic pain also. And the current one that's used quite a bit is duloxetine, which is the brand name is Cymbalta. And in the past, Elavil or amitriptyline or related compounds were also used. And these can make people feel a little sleepy, and they're often used just at night. But again, these have to be individualized. Narcotics are a question that comes up in patients who have severe pain. And again, these have really not been shown to be effective in pain management in neuropathic pain in all the studies that I'm aware of. And for a lot of reasons, including addictive potential, we discourage these. And then there are some creams and that have things like lidocaine or capsaicin in them that people can rub on their feet and hands if the pains are primarily there. And they even have patches that you can put on like Band-Aids over your feet with lidoderm. So again, I'm going through these pretty quickly, but I just want to mention these as items that are out there, and it obviously has to be individualized. Another question people are concerned about is they're worried about what's called anticipation, in which their children might be more affected than they are. And for the vast majority of CMT, that's not a concern. Not every person with the same type of CMT presents exactly the same. So somebody in the family can be more or less affected than the other, although usually it's not an extreme difference. But again, there's not a literature supporting the next generation being worse than their previous generation. Now I'm going to move to the next set of questions. People often want to know what type of exercise or activities are good or bad with CMT. And again, this is an area which really is helped by physical therapy. But in general, we feel that that exercises that are good for stretching and are low impact, but good for the heart and lungs are excellent for CMT. And we try to discourage exercises that require a lot of pounding on the joints. And as extreme examples of this, we might want to encourage riding a bike rather than jogging, an ellipse machine rather than a treadmill, and stationary bikes are great. I want to say something else. I'm forgetting what my thought was. Oh, I think that stretching activities like yoga really seem to resonate well with patients with CMT. Patients aren't often able to do all the postures in yoga, but I think to do what they can. I think many people find that very helpful. Now, braces are a big issue because many people with CMT feel that wearing braces, particularly those that come above your ankle to support your ankle, are a sign that your CMT is progressing and that it's because you won't be using your legs as much that you might be causing more atrophy. That's generally a sentiment that, at least for myself, I discourage. I think that CMT typically doesn't progress all the way up the leg, but it can progress at the ankles. So you have increasing trouble moving your ankle up and down and sideways. And you're really in danger of falling and breaking a leg and then being in a cast and really becoming immobilized for months, which can cause more atrophy. And wearing braces allow people to do things that they couldn't do and that they like to do. And this can range from being able to walk around without falling. It can improve fatigue because you're not concentrating all the time on where you're walking. And I have patients who are able to do things that they couldn't do without the braces, like playing golf or hiking. So I think that those, really good ankle support is really key to managing patients with a CMT. And it's not making your CMT better by delaying the use of those. It's making your life better by using them. And then the next issue, which I didn't really get into, is the genetic testing, interpreting the results, variants of uncertain significance, the costs, and I'm going to leave that for Carly. So I'm going to stop now and just open this up for questions if there's questions I haven't answered. Thank you.
Okay. Hi, Dr. Shai, can you hear me?
I can, but let me see if I can get out of this, my slides. Hold on.
Okay. We see just you. We don't see your slides anymore.
Okay. Can I show off my CMTA shirt again?
Yes, let's see that. Woohoo! That's one of my favorites. Thank you. Thank you for that incredible presentation. Your slides were clear, your volume, your sound, it was wonderful. Everything came through really well.
Thank you.
So I want to thank everyone in advance for their patience as we navigate our way through some of these questions. First, we're going to start with the people who have raised their hands, and if I don't say your name,
sounds like elementary school.
I know. Let's do this in an orderly fashion. So I'm going to call on Maika Gresham, and I'm going to hand you the mic, which means you should, in theory, unmute and be able to ask your question. Okay, here we go. Maika, let's see if we can hear you. Oh, there we go. It's working.
Hi.
Hi, welcome.
Hi, thank you. Hi, Dr. Shai. Hi, Lauren. I wanted to ask you if you recommend hand surgery.
So again, I'm not a surgeon, so I don't want to oversell my expertise. Okay. But it depends to me on what the surgery is expected to accomplish. So it can't make the weakness just go away. But often the hand problems that occur in patients that I see with CMT involve fine dexterity and sort of pinching movements with the index finger. I don't know if you can see my hand here, and the thumb, like this kind of thing, which you might use buttons or maybe putting an earring or something like that. And some types of CMT have really affect, for example, the thumb more than the index finger in terms of that kind of movement. So there are tendon transfer approaches that are used in those occasions. But I think the goal has to be clear that doing that kind of surgery, at least to me, would enable you to do some of those movements that you can't do now, because they won't make the overall weakness in the hands go away, for example.
What will be the benefit? I have carpal tunnel and I have weakness. So would it be any benefit then to do the surgery?
Well, it depends on the individual person. So as I said, if the surgery would enable you to do what I just said that you can't do now, that would be a potential benefit. Now, the issue with carpal tunnel is sort of a gray area for a couple of reasons. One is that many types of CMT have slow nerve conduction velocities, as you know, CMT type 1. And so it can fool people sometimes because that's one of the ways that you can diagnose carpal tunnel syndrome. So they have to be careful that there's a change between what's called the median nerve that's not found in the ulnar nerve, for example. And then there's always a concern in people and caregivers that if somebody has damage to a nerve, having that nerve handled physically during surgery, you know, we don't want to do something that would exacerbate the damage. So I know there are people that feel if it's a clear carpal tunnel, that a surgical approach is merited, but I just think it's something that has to be looked at very carefully. And going beyond that is sort of beyond, I think, what we can do on this call today.
Thank you.
Thank you. Thanks for your great question. Okay, next we are going to bring Virginia to the stage. Virginia, welcome. Can you hear us?
Yes, can you hear me?
Yes, we can. Go ahead and ask your question.
Hi, Virginia.
Hi, good morning. Dr. Shah, our son has had an undiagnosed CMT2. He was a patient of yours.
Okay.
And we have now learned that he has the SORD deficiency. Is he now a CMT4 because of the recessive gene? Or is he still CMT2?
No. So that's a good question. And to me, he would become CMT4. So he was diagnosed as CMT type 2 because it had an axonal peripheral neuropathy, but we didn't know the cause.
Right.
And now with the SORD cause being known, which is a recessive condition, we would classify it as CMT type 4. To the best of my knowledge, it hasn't been assigned a letter yet, but there's a lot going on with SORD, as I suspect you know.
Yes, there's a lot of exciting news with SORD. So yes, thank you. Okay, good. We were just curious about that after watching the slides a minute ago.
And we thank you for getting him diagnosed and all the help you did at the clinic. It was well worth the trip.
Yes, very much so.
Well, that's very kind. It means a lot to me and all of us to have that feedback.
Thank you.
Virginia, did you stop by the Applied Therapeutics table in the lounge?
I did not, but we are very well aware of what they are doing. I'm very grateful for their work.
Yeah, they're here today, so you can always pop in and say hello. Thank you for your question. All right, we're going to send you off the stage.
Bye, Virginia.
Okay, let's see what is popping up. Okay, this might be a genetic question, Dr. Shai. So if you want to, I'll just read it to you. It says, recent genetic test VUS for CMT2 with confirmed small fiber. Oh, perfect. There it is on stage. Our tech team is amazing.
Okay. It's just common. So I can't read the end of the question. Do small fibers, nerves, then what's the next part of it?
It says, do small fiber nerves have axons too? Will the EMG progress to below normal in CMT2?
Okay, so that's really a good question. And the EMG, and when we're talking about the EMG, we're not so much talking about poking people with the needle part of it here. We're looking at the nerve conduction part. And the nerve conductions measure the speed of the large fibers. We try to find those waves that we look at. We look for when they start, and those are the fastest conducting, biggest fibers for both the motor and sensory nerves. So the pure small fibers are not measured well by nerve conductions. And if people have a pure small fiber neuropathy, they may even have normal nerve conductions. So when there are changes on the nerve conductions, that means there are larger as well as small fibers involved. So if there's reduced sizes of the waves, reduced amplitudes, that would mean there's axons damage that are not just small fibers. Now, and small fibers have axons. That's how they connect, right? So you have to have an axon to be able to transmit a message from your skin to the spinal cord and up to the brain. So if there wasn't an axon, there wouldn't be any way to do that. And those fibers are also ensheathed, in other words, surrounded by Schwann cells, which are the cells that make myelin in larger axons. But in this case, in those small fibers, they don't really make myelin, but they still protect the axon. And those have a name of Remac bundles. But again, because we have sort of a broad use of the term CMT for genetic peripheral neuropathies, excuse me, myself and others often include the small fiber neuropathies as under the umbrella of Charcot-Marie-Tooth disease. And there are specific genetic causes that are known to cause some small fiber neuropathies.
Okay, great question. Let me navigate over here to the chat. Okay. Someone mentioned remyelinating drugs. You know, I know there's some of that going on in the MS world, which is, of course, the central nervous system, and we're the peripheral nervous system. Is there any hope for remyelination in the CMT arena, Dr. Shai?
So first of all, the difference between MS and CMT type 1, besides the fact that one's in the central nervous system, one's in the peripheral nervous system, is that MS is an autoimmune disease, and often it has relapses that come and go. And in that setting, parts of the central nervous system axons get demyelinated and remyelinated. So demyelination and remyelination are not really thought to be part of the course of CMT type 1, which is more of a slowly progressive disease. So, okay, so far, okay. So in CMT type 1, at least at my level of understanding, in most instances, even if the myelin's abnormal, the cells that make the myelin are still on the axon. The myelin they're making is just not normal. Okay? So those cells haven't gone away. And in the peripheral nervous system, the only times that there are remyelination that I'm aware of is when those cells actually go away. And that can happen sometimes in diseases like Guillain-Barré disease or something called CIDP. And those are immunological diseases also, not genetic diseases. And in those situations, when the axon is bare and there's no Schwann cell on it, the Schwann cells near that gap can proliferate, in other words, divide and new Schwann cells can come and attach that bare area and remyelinate it. But to the best of my knowledge, that's not a feature of CMT. That's a feature of the immunologically caused demyelinating peripheral neuropathies.
Okay, excellent.
And I mean, that's just my understanding. So, I mean, but that's the best I can do.
Okay. I see some genetic questions in here, and I would refer you to the next session with Carly Siskind. She will be covering a lot of the questions that I'm seeing here in the Q&A. One person asks, actually, let me try to show the question on stage, Dr. Shai. Recent EMG testing indicates both a velocity and an amplitude below normal range. Is there a type of CMT that is both demyelinating and axonal?
So for me, that's a great question because it allows me to emphasize a really important point that I didn't go into so much on those nerve conduction slides. That let's just take CMT1 as an example where we have slow nerve conduction velocities. The main problem is with the myelin. But if you look at measures of severity, with our clinical outcome assessments, it's been known for a number of years that the severity doesn't correlate very well with the extent of the demyelination. What it does correlate with is the extent of axonal degeneration that occurs as a consequence of the demyelination. So when myelin behaves abnormally, like in a demyelinating peripheral neuropathy, its communication with the axon or the nerve fiber underneath is disrupted so that you get axonal degeneration and damage. So if you look at the nerve conduction velocities, particularly in the leg on that patient, you'll see that there'll be slow nerve conduction velocities, but there also will be smaller amplitudes. And that's a result of the secondary axonal damage. And it's a reason why we, at Centers of Excellence, we insist that nerve conductions get done in the arm, because this secondary axonal degeneration can be so significant in the leg that if you try to record nerve conduction velocities in the leg, you won't be able to get any potential. And it'll look like an axonal neuropathy, even though the main problem is with the myelin. Just to drone on for a second on this, if you think about the Schwann cells in CMT type 1, all of the Schwann cells that make myelin along the whole length of the nerve are affected, but weakness or sensory loss is usually worse at the feet or the hands compared to higher up the leg or arm. And that's because that's where the axonal degeneration is worse. Okay, so again, that's a regular feature that you would have reduced amplitudes in addition to slow nerve conduction velocities. It usually is worse at the ankles compared to the arms.
Gotcha. Excellent, excellent information. Thank you so much, Dr. Shai. So we are going to wrap up this session. We are so grateful to you for sharing your time with us and the wonderful information, and also just being the heart of the CMTA community with the clinicians and scientists. Thank you, Dr. Shai. And we'll see Dr. Shai again this afternoon. He is leading the 1B, 1X type 1's subtype session, not the 1A one, but the other ones. And so please join him again this afternoon if you fall into that category. And so once we hit end session, everyone, you will see at the top of your screen, you can choose session and navigate your way to the next session. You can choose between genetic information with Carly Siskind or surgical outcomes with Dr. Pfeffer. And we thank you for being here with us today.
Laura,
take care. Yes.
Laura, can I just add just one last thing?
Of course.
So even though we don't have cures for the types of CMT, we're really on the road for that, as many of you know and we'll hear about later today. And we've learned a lot about the natural history of the different types of CMT. And the only reason that's happened is because of people on this call and people like them. So it's really a partnership between families and patients with CMT and investigators. And I think that's sort of a unique situation in the CMT world. So I just wanted to thank all of you for your partnership in these endeavors. So, okay, thank you.
Hear, hear. Thank you, Dr. Shai. Bye, everyone. See you in another session.
Okay.